Okay, seeing that it's 8:01, we will get started. Good morning, and thank you for joining us for this webinar presentation on Lyme disease in Simcoe Muskoka. My name is Nicholas Shepard-Jones. I'm a medical resident in public health and preventive medicine at the University of Toronto, currently on placement at the Simcoe Muskoka District Health Unit. Today, I'll be co-presenting with Dr. Colin Lee, who is Associate Medical Officer of Health at the Health Unit. So please be advised that this session is being recorded for your own future reference and for those who are unable to join us today. By the end of this session, participants will be able to recognize that the risk of exposure to black-legged ticks is widespread in the Simcoe and Muskoka regions. We'll be able to list and interpret appropriate diagnostic tests for Lyme disease and distinguish these from surveillance activities, to describe Lyme disease prophylaxis and treatment in accordance with updated clinical management guidelines, and to describe when and how to report suspected or confirmed Lyme disease to public health authorities. The presentation will be structured as follows. I will begin by covering the epidemiology and surveillance of Lyme disease in our region, and then discuss the clinical evaluation and management of confirmed or suspected exposure to an infected black-legged tick. Dr. Lee will then continue with the clinical evaluation and management of confirmed or suspected Lyme disease and proceed to discuss patient counseling, reporting requirements, and Lyme disease controversies. We have blocked off 10 to 15 minutes at the end of this presentation for questions and answers. If a question comes up during the presentation, we've asked that you please submit it to us via the chat function, and we will do our best to answer as many as we can in that Q&A section of the talk. So let's get started with the epidemiology and surveillance. What we have here is the classic epidemiological triad of agent, host, and environment. So Lyme disease occurs when a human is bitten by an infected black-legged tick, also known as deer tick, which acts as a vector for the Borrelia burgdorferi bacterium. The incubation period is 3 to 30 days, and the likelihood that a human is exposed to an infected tick depends, of course, on the environment. And black-legged ticks positive for Borrelia burgdorferi are present in Simcoe Muskoka. Their preferred habitats are forests, wooded areas, and places with shrubs, bushes, tall grass, and leaf litter. And ticks are most active in the spring, summer, and fall when temperatures are above 10 degrees centigrade. Unfortunately, the risk of Lyme disease will only continue to grow in our region and beyond. Climate change is driving expansion of black-legged tick habitat. The increased temperatures are also causing a longer transmission season, as well as an increase in tick numbers in areas where we have established black-legged tick populations because of accelerated life cycles. If you look at the figure to the right, you have a modeling map that shows areas where black-legged ticks are known to be endemic. And long story short, you can see that the red area, which is representative of high endemicity, really will expand significantly over the course of the century. Climate change not only affects tick habitats, it also affects humans. And when temperatures are more favorable, humans are more likely to go outside, enjoy the outdoors in potential tick habitats. And so to assess and qualify the risk locally, we engage in surveillance activities. And so we distinguish active surveillance from passive surveillance. The goal of active surveillance is to identify areas with established tick populations via tick dragging. Tick dragging, which is depicted in the image to the left, is conducted twice yearly in May and October, and this is done by our public health inspectors. If a tick is found, the geographical location is marked and the tick is brought back to the health unit for identification. If indeed a black-legged tick is identified, it is then sent off to Public Health Ontario labs for bacterial testing. Active surveillance is complemented by passive surveillance, which consists of tick submissions from the public and from yourselves, healthcare providers. And of course, we do human case surveillance, so we regularly monitor cases that are reported through the Public Health Reportable Disease System, also known as IFIS. What you have here is the Ontario Lyme disease map of this year of 2021. This is a map that is produced by Public Health Ontario annually. And the yellow areas are estimated risk areas for Lyme disease. So basically, are locations where black-legged ticks have been identified or are known to occur, and where people have the potential to come into contact with infected ticks. These estimated risk areas are calculated as a 20-kilometer radius from the center of a location where black-legged ticks were found via tick dragging. So there are two caveats to this map, at least. So first off, established tick populations can exist outside the boundaries of estimated risk areas. We simply cannot perform active surveillance in the entire province. And second, within the estimated risk areas, the proportion of black-legged ticks infected by the bacterium varies widely. And these can be as high as 20%, and this would be the Rouge Valley, or there's a number of areas like Kingston, Brighton, Ottawa. And then there are other areas where that proportion of infected black-legged ticks is much lower, and actually estimates in our area vary, but they have been thought to be around 5%. And so really to be interpreted with much caution. Oops, sorry. If we look at what we have here is a graph that depicts the number of cases of Lyme disease and the incidence rate of Lyme disease provincially and in our region over the last 15 years. And the green line indicates the provincial incidence rate of Lyme disease. And you can see that it has progressed from about 0 in 2006, 2007 to just over 8 cases per 100,000 population in 2019. The dark blue line represents the incidence rate in Simcoe Muskoka, and we see that it too has risen in the last 15 years, albeit not as dramatically as the provincial rate. The light blue bars show absolute case numbers that are reported in residents of the Simcoe and Muskoka region, and you can see that those have gone from 1 to 2 cases per year in 2006, 2007, to as many as 15 cases reported in 2018. And again, unfortunately, these numbers are expected to continue rising. If we look at all the cases reported in Simcoe and Muskoka residents from 2010 to 2019, we see that 32% of exposures occurred in Simcoe and Muskoka. Importantly, 29% occurred internationally, 24% occurred in a risk area identified on the Public Health Ontario risk area map. But also, we note that 10% or 11% of exposures occurred in non-risk areas in Ontario. And this highlights the caveats again of relying on the PHO map presented earlier to assess risk, and also highlights, of course, the importance of a thorough history. As a side note, tick identification during the COVID-19 pandemic has changed. So to respect COVID-19 physical distancing measures, in-person submission of ticks at our public health unit offices are discouraged, and instead we are promoting the use of etick.ca, which is a photo-based ID platform that provides rapid turnaround time, so under 24 hours usually, and really accurate identification of the tick species. So if a black-legged tick is identified, patients are advised to contact their healthcare provider for guidance. What you have here is a screenshot of the etick.ca platform, and I encourage you to visit the website if you have not done so already. And In terms of tick submissions by healthcare providers, I mean, the reasons are really to, as mentioned earlier, support our passive surveillance effort, because these do help shape and help us assess and qualify the risk in our area. This is not meant for initial diagnosis and clinical management because it takes time for lab tests to return. So how? Basically, you place the tick that you may have removed from the patient or that they have brought in themselves. You place the tick in a sterile container with a tight fitting lid, and you complete the surveillance form for tick ID, which is available on the Public Health Ontario website or on our own website. In terms of results, what we expect is that Public Health Ontario lab identification will occur within about 10 to 15 days. And then if indeed, again, it is a black-legged tick, it will be sent to the National Microbiology Lab where they do the bacterial testing, and that takes about 6 to 8 weeks. So long turnaround time, so not to be relied on for clinical decision-making. Let's move to a scenario. So the first scenario is you have a known or suspected exposure to an infected black-legged tick. What do you do? There are 3 steps. The first is tick removal, if applicable, of course. The second is risk assessment. That's the tricky part. And the third is the prophylaxis, again, if you decide to go that route. So we start off with tick removal. If the client still has a tick stuck onto them, use medium-tipped blunt tweezers to carefully grasp the head of the tick as close to the skin as possible. You don't want to grab by the body because that can push the bacteria into your patient. So grasp by the mouth and then pull this tick straight up with a firm and even pressure, and you can clean the bite area. Some even recommend with antiseptic solution. Once removal has been performed, you have to instruct the patient to monitor for signs and symptoms for 30 days. And as discussed previously, recommend submitting the tick for species identification and asking that it be tested for Borrelia burgdorferi. Next, you move on to your risk assessment. So if the exposure has occurred over 30 days ago and the client has no symptoms, then of course, no further management is required, the incubation period being 3 to 30 days. If the exposure occurred less than 30 days ago, then you have to follow these steps. So you need to try and identify the tick, which may be tricky. You have to try and evaluate the risk of Lyme disease or burgdorferi carriage in the area of exposure. And then you have to assess the probability of transmission, and we'll go through each of these. So this is to be comprehensive. We don't expect you to be able necessarily to pick these up by naked visual eye inspection. This is best done under a microscope, but basically to be comprehensive, there are 3 anatomical or morphological features that distinguish black-legged ticks from others. So you have the scutum or the shield, which appears circular. Other species will have more of a elongated shape, and this is something that's found on the body of the tick at the anterior aspect, and it will be dark brown and will remain stable in size even if the tick has fed. Next, the mouthpiece. The mouthpiece is long and straight in black-legged ticks. In other ticks like deer ticks, in other ticks like dog ticks, it can be more narrow or shorter. And then finally, festoons. And festoons basically are wrinkles. And you can see, again, this is a picture of a black-legged tick on the left and a dog tick, I believe, on the right. And there are basically wrinkles or grooves at the posterior aspect of the body on the tick to the right. Those are absent on the black-legged tick. Do recommend this website. These pictures are pulled from the Tick Encounter, the University of Rhode Island. Bunch of great resources there if really you want to plunge into this with more detail. So next, you also have to assess the transmission probability. When a tick bites, it takes time for the bacterium to go, if it is infected, to go from the tick's body into the patient. And so really before 24 hours, the probability of transmission is next to 0. And you can see that it really starts to increase significantly after the 48-hour mark. After 72 hours, really the chance is quite significant that the bacterium has been passed on if indeed it is an infected tick. And so to summarize, basically, criteria for prophylaxis you want to consider are: was the tick attached for more than 24 hours? Was the tick removed within the past 72 hours? And was the tick acquired in an area with a prevalence of ticks infected with Borrelia or Dorferi exceeding 20%? So number 1 and 2 should be relatively straightforward. Number 3 is the tricky part. As we mentioned, there are many caveats with the Public Health Ontario map, and so it can be difficult to really know whether or not an area is endemic. So, of course, watchful waiting is an appropriate option. It avoids an unnecessary antibiotic course. It reduces antibiotic resistance, and in general, it is a safe approach. However, the client or the patient may have some anxiety. The antibiotic that we do use is relatively well tolerated. It's a very short course. So you can go either way. I think the basics of it is that it is a collaborative approach, and it will be, of course, a patient-centered decision. So lots of caveats. It's not the easiest thing to do, but hopefully this can be a conversation with the patient that goes well. If you do decide to provide prophylaxis, the regimen is a single dose of doxycycline. For adults, that is 200 milligrams. For children, it is 4 milligrams per kilogram with a max dose of 200 milligrams. Note, the efficacy of doxycycline has been, first of all, poorly studied, and second, when in the one study that was most robust, which is a randomized controlled trial from 2001, the confidence interval was very wide. So, 87% seems good. It's of course not 100%, but the confidence interval was 25 to 98%, which is very large. So the bottom line is, please do instruct your patient to monitor for signs and symptoms for 30 days, even if they have received prophylaxis. So at this point, we'll move on to the second part of the talk, and I will pass it on to Dr. Lee to discuss what to do when there is known or suspected exposure to Lyme disease. So I'm going to stop sharing my screen, and Dr. Lee, you can go ahead and share yours.
Thank you. Just give me a second here. Okay. You see my screen now?
Yes.
Okay. How's that look, Nico?
Currently, I'm seeing your presenter screen.
Okay, let's change that. Okay. Is that better?
Right now, it's a black screen. We'll get there. There we go. That's good.
Okay.
Good to go.
Okay, great. So, so thanks for getting up at 8 to attend this. That's great. So when we're looking, I'm going to spend some time looking at the signs and symptoms of early localized disease. As mentioned, it does present itself as early as 3 days and up to 30 days or so. So there's lots of challenges with Lyme disease, and I'm going to be focusing on the challenges more than giving you any answers that you don't already know. But basically, for early localized Lyme disease, the symptoms do overlap greatly with other viral syndromes. I think of it as like a flu or a cold, but without the runny nose and cough, because you can have a fever, a headache, fatigue, muscle joint pain. And of course, there's a more pathognomonic sign of the Erythema migraines, which there's a number of pictures here that do outline it with the bullseye lesion. And what we're looking for is anything sort of greater than 5 centimeters in diameter for someone who has been at risk for Lyme and has other associated symptoms, perhaps. So the good news is that if you do see Erythema migraines, you can pretty well, in the right context, make a diagnosis of Lyme and treat it as such. And it is there in about 70% of persons infected with Lyme. But on the flip side, there's about 30% who don't develop a rash. So you still have to use your other signs and symptoms and epidemiology and perhaps testing as well. So in terms of testing, there is the one test, which is the serology test that's done in accredited labs. And it's the same test that's done whether it's here or in the US in terms of accredited labs. The bottom line, first of all, is that this test performs quite poorly in the first 30 days. We are looking at about a 40 to 50% sensitivity. So unfortunately, sensitivity is as good as flipping a coin. That's the truth of it. So it makes it difficult to use it certainly to rule out disease. So what it does detect Lyme antibodies. The antibodies, because it does take days to weeks, will decrease the sensitivity in the first 30 days. After the first 30 days, as time goes on, the sensitivity does start to increase fairly quickly. So it is good when it's later on, when we look at more the latter parts of Lyme disease, but unfortunately, we're obviously trying to identify and treat early to prevent those stages. The antibodies may persist for a long period of time. So if someone who's been infected and treated, it's very difficult to use the same test to look for reinfection. You'll have to wait for an increase in those specific antibodies. So it is a test that's used to support clinical suspicion, but it really can't be used in isolation for diagnosis. So it's a two-step screening. It's a two-step test. They start with the ELISA screening test, and that's in order to increase the specificity of the test. And if that's positive or equivocal, then they do the IgM and IgG Western blot test. And so if it's negative, it will be reported as negative. And I mean, if there are still signs and symptoms, certainly not unreasonable to submit another sample 3 to 6 weeks later to see if the test becomes positive, because it does take a number of weeks. But again, that really is not useful in the context of someone in front of you where you're trying to decide whether to treat them if they do have clinical signs and symptoms. So here are some of the numbers for the sensitivity. It's about, like I said, about 40 to 50% in localized cutaneous disease, what you're likely going to see in the first 30 days. And then when it reaches about 1 to 3 months, it increases to about 85%. And then in the latter stages, in late disseminated, we're looking at about 95%. The specificity of itself is fairly high. It's at 98%, but just, of course, you know that if you use a test that has a high specificity in a sort of low prevalence population, you're still going to get a lot of false positives. So, it's not advised to try to use the Lyme test for patients who are perhaps maybe not have a risk for contracting Lyme, but because they have sort of chronic symptoms of fatigue or muscle aches, and they're looking for a diagnosis. If you test everyone like that, you're going to get some, a number of false positives, even though the specificity is high because it's a low prevalence population. Early disseminated disease, you start to see some of the neurological involvement, the carditis and the arthritis. And we're trying to avoid this, obviously, by identifying early, if possible, and treating during the first 30 days. And then in late disseminated, you can get Lyme arthritis. Although the testing is highly sensitive at this time, again, we have missed sort of an opportunity to treat these cases early. So that's really the challenge of trying for Lyme, is to identify early a syndrome that is, very much so like any other syndrome, viral syndrome, and you've got it's pretty lousy test to use. And for the patient, it's great. There's a treatment that can help them. For the clinician, it makes it a little bit more difficult because there is a treatment. So you have to make a decision early based on incomplete information. So I think many of you have already seen this algorithm. It's from Health Quality Ontario. This was put out about 2 or 3 years ago, I believe. And it's a sort of a 2-pager that provides you with an algorithm for what Dr. Shepherd-Jones had talked about in terms of prophylaxis, and then an algorithm here for early localized disease. And on the back side of it, there is also some information on epidemiology and treatment as well. So just full disclosure, I was part of the small working group that came up with these guidelines. So I can tell you when we were formulating it, the evidence for various aspects of this is not high sort of quality evidence. And when we had this working group, we had we had people who were had lived experience, as well as people who were I call them Lyme advocates, because they are of a sort of minority part of the sort of healthcare provider spectrum who you may have seen encountered in the news or literature, or even in the patients, who advocate for what I would say sort of non-mainstream treatments and diagnoses, and so it was difficult to try to see what the evidence was there, and then also the sort of more mainstream evidence. So essentially, if they don't have any symptoms, you really don't want to do any testing, because there's no need to do that, and the testing, again, like I said, although very specific, you might end up getting a false positive. So let's see if I can help you go through this. So like we said, it's about 3 to 30 days after exposure. So if you do see the Erythema Migraines and it's greater than 5 centimeters, generally speaking, and this person does have some contact with ticks, you can pretty well, give that provisional or clinical diagnosis and treat it as localized Lyme disease. You can do the serology if you want, but if it is negative, your interpretation of it is likely going to be a false negative. And then for this for this part of it, you're looking at symptoms that are fairly non-specific. And then the next step is really to see what are the chances of them having encountered a tick. So this box is fairly easy if you have someone who is always indoors, someone perhaps who lives in a long-term care home and is housebound. Certainly, if there's no real possible contact with ticks, that's highly unlikely. Then that's not going to be on top of your diagnostic differential. You can either rule it out, or you could consider doing Lyme disease serology, again, bearing in mind that there are potential false positives. On this box, if they do travel or hike a lot, or in areas where there is quite a bit of Lyme, then certainly that increases your index of suspicion. And if they have the signs and symptoms and the epidemiological risk, you can certainly treat them as such. And as discussed, serology is really going to help you if it's positive, but if it's negative, you're likely going to ignore it because it is likely a false negative. I'll give you an example of someone that I saw just gratuitously at urgent care clinic. This guy came in, he was a young guy. He said, I think I have Lyme disease. I said, okay, so what are your symptoms? He said, I have a bit of fever, muscle ache, but no rash, a bit of a headache the last few days. And then he says he's been hiking. Oh, I say, okay, well, that sounds like could be potentially high risk activity. And so I asked him, where did he hike? And he told me he was hiking in the area of Lyme in Connecticut, the place where Lyme disease was named after. So needless to say, I did treat him, and coincidentally, a few days later, I did give him a call back, and he did have a rash, and I did take serology just for academic purposes, and it was positive. But however, not all our patients are going to be that simple. We're going to be seeing mostly people in this box where they do a certain amount of walking with their dogs or hiking, or maybe there's a lot of bush around their house. I think this is the most challenging area. I mean, if ultimately, I think you kind of have to ask yourself is, what is your index of suspicion? If it's high enough such that between you and the patient, you're not going to accept a negative test as a true negative, then I would consider treating them for the disease. Because there are truly what I would call post-treatment Lyme disease syndrome, where even though they're treated, and they can have chronic symptoms such as arthritis, fatigue. That is not that can be decreased if it's treated early. So that's really the conundrum you have. And the treatment itself is not benign in the sense that it is 21 days of an antibiotic, so it is a lengthy treatment. It has to really be the discussion with the patient. Some patients are more concerned about Lyme, some people are not at all. So this is really a difficult part. I think if you have a very low index of suspicion, and you would accept a negative test, and certainly do the test and reassure the patient when it comes back negative. And if it's positive, then then you can certainly treat. So as I these just basically is a slide just to summarize what the challenges are. It is a difficult diagnosis to make accurately and with confidence, I would say. What we're really waiting for is a good test. We're waiting for a good PCR test, not too dissimilar to what we do for like chlamydia and gonorrhea. And HIV. HIV, we used to have an ELISA test as well. So we don't see it too often clinically. The existing risk areas are expanding. So there's just more risk of black-legged ticks and infected black-legged ticks. The map itself is not all-encompassing because there is risk outside the yellow areas that are identified by Public Health Ontario. And we don't do active surveillance on sort of everywhere. So even though the area might be white, we certainly can't rule it out. The maps don't provide a percentage of infected black-legged ticks. And like Dr. Shepherd-Jones said, our area is about 5%, but we don't know which areas are perhaps more concentrated. There's also travel-related Lyme from the Europe and the US. If they're coming back from Europe and you want to order the serology test, you actually have to write down a European Lyme test. The decision rules around antibiotic prophylaxis is difficult for clinicians to implement because of the third criteria of endemicity of 20% or more. Again, that's not static for a lot of areas and unknown in some areas. And I think the one last thing that is becoming more frequent is just there's a lot more diagnostic treatment controversies that are both in the public sphere by a very vocal minority of both healthcare providers and Lyme advocates. They generally are advocating for longer treatments of Lyme, for instance, for prophylaxis. They don't believe doxycycline 200 is enough. They advocate for a 21-day course, a full course of treatment for prophylaxis. And for treatment itself, they advocate for about 4 to 6 weeks of an oral of oral doxycycline, and then amongst other things, which we'll talk about, have a belief that chronic infections can occur, meaning Lyme can persist, that the parasite can, the bacteria can persist in the system. So let's look at the treatment. Okay, the principles, of course, to try to resolve the signs and symptoms, prevention of relapsed active infections, and avoiding the complications. So we're trying to treat it early and accurately, and that's the balance we're trying to find. So in the mainstream literature, I use the word mainstream because of this sort of minority of Lyme advocates, I would say. The literature does show similar efficacy for all three. I would say that there is some mainstream guidelines that do recommend doxycycline as the first line. So certainly wouldn't go wrong in choosing that as the first line for adults in terms of looking at various guidelines. Your selection is going to be obviously based on age, and for extracutaneous manifestations after the first month, the preferred medication is doxycycline, but for early localized, like I mentioned, it's those three seem to be at equal footing. Pregnancy, drug allergy, and sun exposure being that doxycycline, as you know, can make someone a little bit more photosensitive. I'll talk a little bit more about doxycycline in terms of the historical risk of tetracyclines of teeth staining for those age under 8 in a second. So let's look at the I mislabeled this as points of contention, more so sort of points of slight difference. So for erythema migrans or localized early localized infection for the first 30 days, 21 days seems to be the standard, both for the Health Quality Ontario guidelines, as well as there's a newer set of guidelines, which some of you have seen, and I just recently saw it because I've just been busy with COVID. I haven't really looked up the literature much. This is from the Center for Effective Practice, which is located in Toronto, and I believe it's a non-profit organization that is made up of, I think, Ontario family physicians looking at guidelines. They are, I think, quite well known in the family practice sphere. And they have a very good document that came out in late, I think, November of last year. So this is more up to date in the sense that it's come later. Having said that, the literature hasn't changed from here to here, from the HQ01s. So anyway, 21 days is the preferred number, is what I would say. The dosing of agents is a little bit different from one to the other, and one HQ does a more high dosing versus CEP does a sort of a regular dosing. And then there's the choice of agent in children. Now, in the Infectious Disease Society of America, which is sort of the mainstream infectious disease association, does state that there is growing consensus that doxy is safe for use for at least up to 14 days duration. And this is the big reason is this doxycycline's a newer generation of tetracycline, and they haven't seen sort of staining of teeth as a risk for up to 14 days. Now, interestingly, the American Academy of Pediatrics state that it's safe for up to 21 days in children, and they cite it specifically for Lyme disease. So certainly 14 days is the minimum consensus, 21 by obviously the American Academy of Pediatrics, which is a fairly well established and well recognized body that is saying it's safe for 21 days. So what are your choices? I give them as choices because I don't really, when I look at the evidence, they all look the same to me, but they have just decided on an approach that's a little bit different from one to the other. So if you look at the Center for Effective Practice, they have stated explicitly that first line should be doxycycline for both children and adults. The dosing for adults is fairly standard, 100 BID. And then for children, it's 4 milligram per kilogram. divided into 2 doses and for 21 days. The amoxicillin is the usual that we normally would use for dental abscesses and stuff like that, at 500 TID. And for children, it's a similar regular dose amoxicillin. So fairly straightforward there, except they do recommend as a first line. The HQO guidelines from 2 or 3 years, but my belief is they're looking at the same data. I was part of the HQO ones, and I did look at the CEP, looking at the references, they were exactly the same. The recommendation is there, doxycycline or amoxicillin or cefuroxime, which I haven't put here, are on equal footing. The doxycycline is exactly the same dose. The amoxicillin is a higher dose. That was what was decided, and that it would be. And I believe this might have been influenced by the sort of the Lyme advocates. So take it for what it is. But in any case, I honestly don't see much difference between the 2 guidelines in terms of the evidence supporting either. Doxycycline in these guidelines were looking at for just 8 to 18 years of age. And they looked at a loading dose and then a regular dose after. I mean, certainly I think, and then amoxicillin for less than 8 years of age. I mean, from a practical perspective, purely from that, I just use doxycycline as first line for adults. You know, just because it's you know, there are some guidelines that recommend as a first line, and some patients who come in who expect doxycycline because when they read on the internet, many websites do say first line. Many of them are from Lyme advocates. For children, amoxicillin, banana flavor, you can't go wrong with that. Compliance is usually great with that. I don't know what doxycycline tastes like for children, but I generally use amoxicillin for kids who can't take pills. And then also I'm just more conservative with the teeth staining. And but mind you, I just, you know, sort of read about the American Academy of Pediatrics stating it's fine for kids, even under 8, just recently. So my recommendation is you can use either guidelines. I mean, this is obviously easy to remember in terms of the dosing. And to me, either is fine, doxycycline or amoxicillin. If there is a problem with doxycycline or beta-lactams, then azithromycin would be or macrolides would be your next bet. So in terms of reporting, I think, as you know, many of our reportable diseases are passive. We get the lab confirmation easily without any help from you. But because you know, Lyme can be diagnosed clinically, it will help with our surveillance if you can get someone in your office to just send us the form to let us know, so that we can have a more accurate count of what we're seeing in terms of human Lyme. Patient counseling can be important, I should say, because if you don't get ticks on you, then the chances of it obviously will be a lot, is essentially 0. Light colored clothing, long sleeve shirt, long pants, closed toe shoes, tuck pants and socks, you know, stuff that I like to say, stuff that unfortunately I personally have difficulty in following, especially on a nice summer day. But that obviously would be very important if you are going into the bush or areas where there is known to be quite a bit of black-legged ticks. There's insect repellent, and you know, full body tick checking is also important for people who spend a lot of time outdoors. To have either yourself look at your body in the shower, or someone else look at your back or your hair. Pets can also sometimes bring ticks into homes. And then also, if you live in an area where there is a lot of bush and wooded areas, there are landscaping solutions to have a barrier so that your backyard itself is not is at less at risk for having ticks. Okay, so I'm going to go to the next section, hot topics or controversial topics. And talk about what is termed, I think, post-treatment Lyme disease syndrome. It's really defined in the mainstream sort of mainstream medicine that most of us practice as persistent or recurring symptoms for 6 months following appropriate treatment in patients with confirmed Lyme disease. And the risk factors do seem to be a delay in diagnosis, the severity of initial symptoms, neurological symptoms, and underlying co-infection that may not have been treated. The exact cause is not known, but like most sort of chronic things, it's thought that it's possibly in tissue injury and excessive inflammatory response. At this time, there is no credible scientific evidence that this syndrome is caused by persistent infection. The reason why I state that is because for some of the Lyme advocates, the minority, sort of non-mainstream, they do believe that there is chronic infections, although from what I can see in the literature, there hasn't been an isolation of the bacteria in chronic patients. There have been some placebo-controlled trials on the efficacy of prolonged antibiotic treatment, and the conclusions at that time was that it was not beneficial for that treatment. You may have seen patients coming in, saying, "Hey, I've been prescribed this antibiotic treatment," and I've seen it before where they are getting treatment from a Lyme physician down in the States where they have a PICC line and they're basically cycling through the sort of ICU type antibiotic IV medications for months on end. It's certainly not mainstream treatment, but certainly out there in the mainstream intranet and advocacy of a minority. There's also the testing part where I'm sure you've heard, or at least may have seen a patient coming in once that you have already ruled out Lyme disease, both perhaps clinically and also through the usual testing. And they come in from a lab test from the state saying, "Hey, look, I've got a positive test, got a positive Western blot test." They say our test is lousy. Essentially, what they're doing is that they're going to these unvalidated private labs that are doing these unvalidated tests, where they are changing the characteristics of the Western blot test such that it doesn't require as many target antigens, and therefore increasing the chances of a positive test, but in the same time increasing the false positivity rate. They're also just not using the ELISA as well. This is from a number of years ago, but they did do a little experiment. They sent about 40 healthy individuals to private labs and also to the usual accredited lab to get Lyme testing. None of these people have symptoms, nor have they have any kind of risk, a known risk or bite. And almost 60% of the patients tested positive on the private lab unvalidated test versus none on the CDC test. So I think it's essentially these tests are being done, and there are a number of people who might be told that they have Lyme when they do not. And it's difficult on you when you get patients like that, but I think you just have to explain to them that we do the same accredited tests that they do in the US, and the ones that are doing are not accredited and have a really high chance of a false positive. So having said that, we do have common goals with the Lyme advocacy groups. We want to know, have a better understanding of the emerging epidemiology, optimize resources and methods for prevention. We do want to monitor the evolving science. We want to improve the diagnostic test. That's the one that we really need. It's a good PCR test, both to diagnose it early, monitor treatment, and also diagnose reinfections. We do want to try to figure out how to manage these post-treatment symptoms, not too different from what we're seeing in some COVID patients. And of course, increase the awareness of it so that we can prevent, diagnose early and treat appropriately and early. Where we diverge is really some of the pathophysiology, where, like I said, they do believe in this persistent Lyme disease, where after sort of mainstream treatment of oral antibiotics, they believe that they're still persistent in it and they need to be treated for months on end. Their lab diagnostics, they go for the more the test that's more likely to be positive, with the trade-off being higher false positivity. And then the treatment itself is certainly much prolonged there for both prophylaxis and treatment. So in terms of resources, I think the first two are probably your go-to ones. This is a 2-pager, so it's a nice, quick and dirty a way to and then I'm sure a lot of you have seen it because it's been around for a while. This is the newer one, and that is much more, I think, family practice oriented. It's about 10 pages. It's longer. And it's, like I said, it's a little bit different from the treatment perspective, but I think both are valid. I think HQO will have the opportunity at some point in time to relook at it and see if it's going to marry up. The Public Health Ontario website does have good information on epidemiology and ticks. And I didn't put it down here, but the eTick app is also very helpful to identify ticks within 24 hours for both your patients and potentially yourselves. The Infectious Disease Society of America Lyme disease guidelines finally got updated 19 years after the first set. This is like a 50-pager. It's got everything you want to know about the science behind it. And then the Canadian Association for Physicians for the Environment, talking about again the climate change and how it's affecting our epidemiology as well. So I'm going to stop there. Those are our email addresses. Feel free to email us if you have other questions in the future. And what I'm going to do is I'm going to just stop sharing, I think, and then pass it on back to Dr. Shepherd-Jones. And
yeah, that's great. Thanks for that second part, Dr. Lee. And we have about 7 minutes. We're happy to go over time, but we understand that you may be on tight schedules and have full days ahead of you. So far, we do have one question. I'm happy. I will start with this one, and then if you have questions, you can definitely turn on your camera or speak up, or you can throw it in the chat, and we'll try and address it. But the first one was about tick submission and tick submission by healthcare providers, and the question was, should the tick be dead or alive? And Dr. Lee, I think if you want to go ahead and
sure. Yeah, no, it doesn't have to be dead or alive. I think you just put it in the empty urine bottle without any liquid in it, and that's fine. Just to let you know, it does take like 7 to 14 days to get a tick identification, and then they send it to the lab in Winnipeg, to the national lab, to test it for positivity, and that takes another 3 weeks. So it is a long time. It's really more for surveillance purposes. I can see there is a possibility for use if you have a really low index of suspicion. It's early on and you're not going to treat them anyway, and you get the result back 7 days later and it's not a black-legged tick. You can reassure the patient before the 30 days is up that, don't worry about it, that tick doesn't carry Lyme.
And the follow-up question too by Dr. Gabor is also, can we share the slides? I think, so we will, this recording, it will be available publicly on our website. Happy to circulate it to those who wish, and you can throw your email address in the chat if you'd like a copy of this. And I don't know about the slides themselves. I don't see that there's any problem with that, but go ahead, Colin, if you want to.
Yeah, no, we'll post the slides as well.
Yeah.
I just want to take the opportunity to show you, I've been talking about these Lyme advocates, this non-mainstream. I do want to show you their website because it is very professional looking, and it's, these are all licensed, like a number of them are licensed physicians. And the first time I read it, it was very convincing. So they call themselves, and this is good to know because your patients are going to refer them, the International Lyme and Associated Disease Society, ILADS. They have their own guidelines. And if you look at this, this will sort of give you an idea. Evidence indicates that 20 days of prophylactic antibiotic may be highly effective. And then for early Lyme, you're looking at 4 to 6 weeks of treatment. So if you read it, it's an interesting read, but their evidence is, it's really a very low level of evidence. It's more expert. They rely on expert opinion and on what patients want. So it's challenging. So I'll just stop that again.
We have two additional questions. So the first is, does swimming, showering after exposure dislodge attached ticks? And we do recommend in our preventive behaviors that after people have gone outdoors, we do recommend that folks do a whole body tick check for themselves or for their family members. And we do recommend that actually you do take a shower, because the tick, it will take time for it to grasp on and latch onto the skin. And so if it's still kind of moving around and not yet latched on, then a shower can dislodge it. I don't know if you want to follow up on that.
No, I think I don't have anything. Yeah.
And you can refer patients to our website. We do have an e-learning video that instructs them step by step on how to do the tick check and so forth. So that's one question. The second question here is, how important is it to dig out the mouthpiece broken off in the skin? And my understanding is that, again, that's not where the bacteria are housed, and that's not going to cause an infection. So do your best to remove the tick. And if there is a slight little piece that's left in, I wouldn't worry about it. It will come out, but it's important to just wash the area thoroughly.
So, hi guys, thanks for this morning. Just to expand on that question that I just asked, often they come into emerge, they've already removed the tick, and that little piece, the mouthpiece, is still in the skin, and we're freezing it and cutting it open. So should we not be doing that then? Or should we be going after that? I mean, it is a foreign body, and I'm just not sure what we wanted. Just looking for advice. Thanks.
Yeah, I think if it is clearly still stuck there, it would be wise to remove it. I mean, I don't know. The short answer is I don't know, but I mean, it's obviously irritating enough that it should be removed, because it is. You're saying it's outside the skin, right? Or is it inside Oh, it's inside. Yeah.
I think there's different expert opinions. There's probably no study on that one. But I think it's a balance of the pros and cons. I have seen some literature that suggests that you can leave it in and it will come out on its own. So I think it also depends on the patient preference, but it is a foreign body. So we have another question from Dr. McLean. I've seen a few patients who are telling me they've read or been told any tick can carry Lyme. Do you know where this information is stemming from? I'll leave that one to you, Dr. Lee.
No, I don't. There is a lot of, like I said, a lot of information out there, a lot of Lyme advocates out there. Again, it's sort of the vocal minority. But yeah, I mean, in North America, it's really just the black-legged tick.
So we have one more minute, if there are any questions. If not, we do want to thank everyone for showing up this morning. And again, this will all be posted on our website, so we'll have a copy of the slides and of the webinar. And I don't know if there's something else that you'd like to add, Dr. Lee.
No. Thank you very much. This, unfortunately, Lyme disease is here to stay, and it's a difficult clinical issue. And we're hoping that in the next number of years, we'll get a PCR test, make life a lot easier. But in the meantime, struggle along with it. It is important because there are unfortunately complications from it that can occur. Great, thanks.
All right, thanks so much. Take care, everyone. Bye-bye.